My name is Kori Holman. I'm a hemonc pharmacist at Methodist University Hospital, and today I will be discussing novel oral drug updates. I have nothing to disclose, and I'm going to be discussing the indications, dosing, and adverse effects of the new chemotherapy agents that have been approved, and I'm going to outline pertinent administration nuances of these new medications. The current state of drug development for cancer treatment revolves around targeted therapy, and there is a particular interest in oral targeted therapy because it decreases the amount of time patients have to come into the clinic. There has been a variable number of new oral agents coming to market each year, with peaks around 10 new approvals for several years, with only one new oral approval so far in 2022. These are the new approvals from 2021 and 2022, with pacritinib being the only drug that has been approved in 2022. I'm going to start with discussing the medications that have been approved for malignant hematology. Asciminib inhibits the ABL1 kinase activity of the BCR ABL1 fusion protein and is also active against the T315I mutation. It is FDA approved for the chronic phase chronic myeloid leukemia in patients who have previously been treated with at least 2 other TKIs, or it can be used in the frontline setting if the patient has a T315I mutation. It is dosed at 80 milligrams once daily or 40 milligrams twice daily for the T315I mutation, for previously treated CML, or 200 milligrams twice daily for the T315I mutation. No dose adjustments are needed for renal or hepatic impairment. If a dose reduction is needed, the first reduction is 40 milligrams once daily or 20 milligrams twice daily for the previously treated CML indication, or 160 milligrams twice daily for the T315I indication. If the patients cannot tolerate this dose, then the medication should be permanently discontinued. Common adverse effects include thrombocytopenia, neutropenia, and upper respiratory tract infections. And patients should have a CBC monitored every 2 weeks for 3 months and then monthly thereafter. And amylase and lipase should also be monitored monthly. This should be administered on an empty stomach, so the patient should avoid food 2 hours before and 1 hour after administration, and they should take this medication whole. Pacritinib is a kinase inhibitor with activity against JAK2. It is indicated in intermediate or high risk primary or secondary myelofibrosis in adults with low platelets. It is dosed at 200 milligrams twice daily. It should be avoided in severe renal impairment or moderate or severe hepatic impairment. If a patient does require a dose reduction, the first reduction is 100 milligrams twice daily. The second reduction is 100 milligrams daily. And if the patient can't tolerate this dose, it should be permanently discontinued. The major adverse effects here are diarrhea, thrombocytopenia, and peripheral edema. Patients should have a CBC monitored periodically as clinically indicated, meaning if a patient is having symptoms of weakness, fatigue, signs or symptoms of an infection, bruising, or bleeding. Coagulation studies should also be monitored periodically as clinically indicated, and an EKG should be gotten at baseline. Pacritinib should be taken without regards to food. Patients should skip any doses that they miss, and the medication should be swallowed whole. Umbralisib is a PI3K inhibitor that is specific for the delta form, and this prevents cell proliferation. It is indicated for relapsed or refractory follicular lymphoma after at least 3 prior lines of therapy, and in relapsed or refractory marginal zone lymphoma after at least 1 prior anti-CD20 based regimen. It is dosed at 800 milligrams daily for both indications. There are no dose adjustments for renal impairment. If a patient has moderate LFT elevations, it should be held until it normalizes and then resumed at a reduced dose. And it should be discontinued if there are severe LFT elevations. If a patient does need a dose reduction, the first one is 600 milligrams twice daily. The second one is 400 milligrams daily. And if a patient can't tolerate this 400 milligram dose, it should be permanently discontinued. Major adverse effects include serum creatinine increases, thrombocytopenia, and increased liver function tests. Patients should have their CBC monitored every 2 weeks for 2 months, and then weekly if ANC is less than 1,000. Liver function tests should also be monitored, along with signs and symptoms of PJP and CMV infection. Patients should have PJP prophylaxis given during therapy. Patients should take with food at the same time each day. This medication should be taken whole, and if vomiting occurs, patients should be instructed to not take an additional dose. Now I'm going to switch gears and discuss the medications that have been approved for the solid tumors. Infigratinib inhibits the FGFR kinase and decreases cell proliferation in cells with activating FGFR amplifications, mutations, or fusions. It is FDA approved only in patients with an FGFR2 gene fusion or amplification, in patients with unresectable or locally advanced or metastatic cholangiocarcinoma. So if a patient has any other type of FGFR abnormality, this medication should not be used. It is dosed at 125 milligrams daily, days 1 through 21 of a 28-day cycle. So you could tell your patients they'll be on this medication for 3 weeks and off for 1 week. If a patient has mild or moderate renal impairment or mild to moderate hepatic impairment, the dose will be reduced. This medication should be avoided if the patient has severe renal or hepatic impairment. If a patient does require a dose reduction, the first reduction is 100 milligrams, the second reduction is 75 milligrams, and the third reduction is 50 milligrams. And the number of days the patient is on this drug does not change throughout the cycle. Major adverse effects include hyperphosphatemia, nail changes, increased LFTs, and ophthalmic toxicities. The FGFR2 gene fusion or rearrangement should be confirmed prior to starting this medication. Serum phosphate should be monitored throughout treatment as necessary, and if hyperphosphatemia occurs, it is recommended to initiate an oral phosphate binder if the level is 5.6 to 7.5, and phosphate levels should be monitored weekly when the level is greater than 5.5. A comprehensive eye exam should be monitored at baseline, 1 month, 3 months, then every 3 months thereafter. This medication should be taken on an empty stomach at least 1 hour before or 2 hours after food. If a dose is missed by at least 4 hours or if vomiting occurs, the patient should not take an additional dose. Patients should swallow the capsules whole with a full glass of water, and PPI should be avoided. However, infigratinib can be administered 2 hours before or 10 hours after an H2RA, or 2 hours before or 2 hours after an antacid. Mobocertinib inhibits cell proliferation in cells with EGFR exon 20 insertion mutations. It is indicated in locally advanced or metastatic non-small cell lung cancer with this specific EGFR insertion mutation. It is dosed at 160 milligrams daily. No dose reductions are needed for renal or hepatic impairment. If a dose reduction is needed, the first reduction is 120 milligrams daily, and the second reduction is 80 milligrams daily. Common adverse effects include skin rash, diarrhea, anemia, lymphopenia, and increased serum creatinine. The specific EGFR exon 20 insertion mutation needs to be confirmed before starting mobocertinib. Ejection fraction should be monitored at baseline and during treatment, and QTc and electrolytes should be monitored at baseline and periodically. This medication should be taken at the same time each day without regards to food. It does have a moderate or high emetic potential, so patients can be instructed that taking it with food may reduce the nausea. It is also recommended to prescribe an antiemetic to take with the scheduled mobocertinib dose, such as ondansetron. If a dose is missed by more than 6 hours, it should be skipped and resumed at the normal schedule the following day, and the patient should take this medication whole. Sotorasib is the only KRAS inhibitor on the market, and it inhibits the specific G12C mutation, which promotes apoptosis. Because it is specific for the G12C mutation, the hope is that it will have minimal off-target effects. It is indicated in locally advanced or metastatic non-small cell lung cancer with this specific KRAS G12C mutation. It is dosed at 90 milligrams daily. No dose adjustments are needed for renal or hepatic impairment. If a dose reduction is needed, the first reduction is 480 milligrams daily. The second reduction is 240 milligrams daily. And if patients can't tolerate this 240 milligram dose, it should be discontinued entirely. The common adverse effects are diarrhea, increased LFTs, musculoskeletal pain. Patients should have their KRAS G12C mutation confirmed before starting therapy. LFTs should be monitored at baseline every 3 weeks for 3 months and then monthly thereafter. And they should also be monitored for signs and symptoms of interstitial lung disease or pneumonitis. Patients should be instructed to take this medication at the same time each day without regards to food. While patients need to take this medication whole, an oral mixture may be compounded with the full tablets. So patients should be instructed to disperse a whole tablet in 120 milliliters of non-carbonated room temperature water. Water is the only liquid that should be used. Patients should then stir until the tablets are dispersed into small pieces, and patients should be educated that the tablets will not dissolve entirely. They should then drink this within 2 hours of mixing, and the mixture might be pale to bright yellow. Patients should then rinse the container with 120 mL of water and swallow this to ensure that they have taken the entire dose. If a dose is missed by at least 6 hours, it should be skipped and then it should be resumed at the normal time the next day. Patients should also avoid PPIs and H2RAs, but it can be administered 4 hours before or 10 hours after an antacid. Tepotinib is a MET tyrosine kinase inhibitor, which inhibits tumor cell proliferation and is specific for the exon 14 skipping mutation. So it is indicated in metastatic non-small cell lung cancer with this MET exon 14 skipping mutation. It is dosed at 450 milligrams daily. No dose adjustments are needed for baseline renal or hepatic impairment, but if hepatic impairment occurs during treatment, the dose should be reduced. The first reduction needed for any reduction is 225 milligrams once daily, and it should be discontinued if patients are unable to tolerate this dose. The most common adverse effects are decreased serum albumin, increased serum creatinine, increased alkaline phosphatase, and lymphopenia. Once again, the patient should have the MET exon 14 skipping mutation confirmed before starting this treatment. LFTs should be monitored at baseline every 2 weeks for 3 months, and then monthly thereafter. And they should also be monitored for signs and symptoms of interstitial lung disease. Patients should be instructed to take this with food at the same time each day. Patients should take this medication whole. And if a dose is missed, it should not be taken if it is within 8 hours of the next scheduled dose. Tivozanib is a VEGF inhibitor which prevents angiogenesis and leads to cell death, and is indicated in relapsed or refractory advanced renal cell carcinoma after at least 2 prior lines of therapy. It is dosed at 1.34 milligrams daily, days 1 through 21 of a 28-day cycle. So again, patients will be on this medication for 3 weeks and off for 1 week. No renal dose adjustments are needed. If proteinuria occurs during treatment, this medication should be withheld and then resumed at a lower dose once it resolves. And any moderate hepatic dysfunction also requires a dose reduction. The major adverse effects are fatigue, increased blood glucose, increased serum creatinine, and hypertension and diarrhea. Proteinuria and thyroid function should be monitored at baseline and periodically throughout treatment. Hepatic function should also be monitored at baseline. Blood pressure should be checked after 2 weeks and monthly. Signs and symptoms of cardiac failure and thrombotic events should also be monitored. Patients should be monitored for signs of impaired wound healing. And they should also be monitored for reversible posterior leukoencephalopathy syndrome. This medication can be taken without regards to food. Patients should swallow it whole with a full glass of water. And patients should be instructed to hold this medication if it is within at least 24 days before elective surgery. And this medication should not be resumed until at least 2 weeks after major surgery and until adequate wound healing has been established. While there might not have been many new drug approvals, there have been several medications currently on the market that received approvals for new indications. Alpelisib is approved in patients with PIK3 overgrowth. Abemaciclib, in combination with endocrine therapy, can be used in the adjuvant setting to treat hormone-positive, HER2-negative, node-positive early breast cancer. The Ki-67 score has to be at least 20%. Cabozantinib can be used for locally advanced or metastatic thyroid cancer that has progressed after VEGF therapy in radioactive iodine refractory or ineligible patients. Ivosidenib can be used in previously treated locally advanced or metastatic cholangiocarcinoma in patients with an IDH1 mutation. Olaparib can be used as adjuvant treatment of germline BRCA-mutated, HER2-negative, high-risk early breast cancer treated with chemotherapy. Zanubrutinib has 2 indications: relapsed or refractory marginal zone lymphoma after at least 1 anti-CD20-based treatment and Waldenstrom's macroglobulinemia. And avapritinib is indicated in patients with systemic mastocytosis with associated hematologic neoplasm and mast cell leukemia. Thank you for your time today.